Hope Cook with DermCast Live. We have Dr. Martin Zaiac here from Miami, and he lectured us on nails, and we have a few questions from our audience.
Great,
Go ahead.
thank you.
You mentioned about melonychia biopsies. When we're in the fold, if we don't see a lesion, or we don't see any obvious lesion, do you still go and do a punch biopsy, or do you submit just a nail bed?
So if the melanychia is seen in the either lateral nail fold or in the proximal nail fold, or even in the hyponychium, that's more of a sign that it's probably more problematic, because that's what we call Hutchinson's sign.
Right.
Hutchinson's sign, it was described when these melanocytic activations become more malignant. So depending on what you see, if you don't see a Hutchinson sign, your suspicion level is less. What you want to look at is at the base of them. If this is the nail here, if the base is getting wider, let's say it starts narrow at the distal part and gets wider, that means that nail lesion is growing laterally, and that's also a sign. You want to look for color changes. If it's a uniform brown, kind of like your sweater that you're wearing, then we say it's okay, but if it has variations in color, darker, then you want to go for it. So if you're doing a punch biopsy, like what we talked about there, you want the band to be narrow, less than 3 millimeters. So you can do a punch, remove that lesion, or at least get enough material for a biopsy and not necessarily cause scarring of the nail matrix, which then would leave a nail plate scar or splitting of the nail plate. Nobody wants that. If it's wider, then you have to do one of these other techniques like I showed, the tangential biopsy, where you remove part of the nail and just shave that matrix off. But it's important to be suspicious. And if you're suspicious enough, or sometimes if the patient just says, I have a funny feeling about it, go with it and do the biopsy, because you could save someone's life if it is a melanoma.
Right.
Again, if it's a single nail, higher suspicion. If it's multiple nails, chances are very low that it's melanoma.
Got it. Thank you so much.
Great question.
Thank you.
My name is Sherry Anderson, and I'm from Westlake Village, California. So this patient is 8 years old, and he came in, and I did culture. I did a clipping and cultured, and it came back positive for trichophyton. But he does have an older sibling who has psoriasis, so in my head I'm trying to decide between, is this maybe psoriasis? Was the trichophyton just incidental that I found that? So I'm just wondering your thoughts on that case.
I guess everyone must have known that I'm coming here to talk about nails, because you even brought pictures with you. But you know, in the lecture we talked about choroonychia, and it's typical, like I said, in children or young adults to have choroonychia. So this patient does. You said it was how old?
8 years old.
8 years old. So it's expected to have physiologic choroonychia, which is spoon-shaped nails. Now you can have psoriasis and dermatophytosis together, because once you have that separation of the nail, which psoriasis would do, the dermatophyte has a better chance of getting in. So I think that sometimes if you treat as psoriasis and the nail starts to grow normal, that dermatophyte no longer has that habitat to live, and it may get better. But there's nothing wrong with treating them for psoriasis and giving them an antifungal as well. But again, be patient, be patient. But I think that if, any other skin findings on your patient here, psoriasis?
No other skin findings on him, just on his brother has pretty severe scalp psoriasis, but this patient had no other skin findings.
Right, so if you wanted to do another nail clipping and specifically ask your pathologist to look for confluent parakeratosis. So we know with psoriasis, the turnover rate is very fast. So normally the basal cells undergo changes, and by the time they shed in the stratum corneum, they lose the nuclei. So it's called orthokeratosis, or clear stratum corneum. When psoriasis, because that turnover rate is so fast, those nuclei can't come out. So all that dead skin has nuclei. It's called parakeratosis. So if the pathologist can identify that, which they can, then you probably have something that has psoriasis and dermatophytosis together.
And they can identify that from a nail clipping, like a distal nail
They
clipping?
can do that as long as you get enough of the subungual debris. So I don't know, when you clip, but let enough nail grow out so you can get a nice piece of nail, not so much the nail plate, but the stuff underneath that, and ask them to check for confluent parakeratosis.
Thank you so much. I appreciate it.
My pleasure.
Hello, I am Mariana Cooper. I have a general derm practice in Southern Oregon. Can you give us a quick synopsis? I do a lot of skin exams. A quick synopsis on the difference between, a quick clinical difference between somebody with yellow nails versus onychomycosis. On a quick skin exam. So when
Right, but are you talking about all nails involved or few nails involved?
All nails involved. Yeah. a lot of people just with yellow nails on exam.
Right. So if all nails are involved, you're talking about both toenails and fingernails?
Toenails.
Right. So toenails classically have a lot more trauma. Is this person a runner or athletic or
Generally, we'll say
older person?
60 years old, not runner.
Right. So, I mean, usually onychomycosis is not going to affect all the nails. There'll be some nails. One way to distinguish is to look at the bottom of their foot and see if they have tinea pedis.
Right, okay.
If they have tinea pedis, or athlete's foot, however you want to call it, then you would suspect that maybe that could get under the nails. But unusual that you have all 10 nails involved with dermatophytosis. Yellow nails, like I said, can be caused by systemic disease. That certainly it behooves you to send them to their doctor to see if they have anything like that. But it could also just be something that occurs idiopathically or genetically. As we age, things slow down. The nails may not be growing as fast. So then you have this opacity that develops. One of the things that we didn't talk about, but the use of minoxidil for hair, which we know was Rogaine, has been very beneficial. Patients that are taking minoxidil for the hair, not only does their hair grow better, but their nails grow faster too. So on a lot of patients that have this yellow discoloration, I have given them minoxidil to see if maybe we can get that nail to speed up and grow a little bit faster.
And do you ever recommend a nail clipping to secure a diagnosis between onychomycosis if you're unsure, if we're unsure?
If you're not seeing subungual debris, then chances are it's not onychomycosis, you know.
Okay.
What I normally do is check the bottom of their feet and make sure if they have tinea pedis, and it's, you know, I do a KOH and it's positive, or if you send it for a specimen, then I think that, you know, you probably have onychomycosis. But again, all nails involved, very unusual to be onychomycosis. Yeah. It could just be physiological change.
Okay, thank you.
Thank you.
Hi, I'm Chelsea. I'm from actually Jonesboro, Tennessee. I have a question for you. I actually have an example of my own nail, which I've ignored for years, but then I had a patient now come in with something very similar, and so I can continue to ignore mine, but I'd like to know what's wrong with my patient. So essentially, there's a line through here. There's been one long time, not real dark, but you can see it. Always have little splinter hemorrhages around it, and there's a growth that comes out from under it,
Right.
completely separate from the nail, will grow as long as the nail. If you pull on it, hurts really bad, then shows a bloodline all the way down. What in the world? And does that need to be, mine will not be, does hers need to be biopsied?
That's us doctors are always the worst patients. But, you know, it sounds like what you're describing is called an onychopapilloma.
Okay.
Papilloma meaning like a little growth. Most of the time they're benign.
I love that.
They present as erythronychia typically, which is like a pink line. But they can be white, they can be dark, they can be pigmented.
Okay.
Typically they do produce a couple of splinter hemorrhages, and they do have a projection that comes out adhering to the nail plate. Very commonly you get a splitting of the nail, and patients will come in not so much worried about the line,
Yeah,
but
it
they
does
say, you know,
split.
my nail splits and it catches on stuff.
Okay.
So if you look at the nail, like you said, in cross-section, there is a little papilloma there. You can take a clipping of that and send it to the pathologist, and
Okay.
they can make the diagnosis. It's probably a smart idea to do that, because every once in a while it could be a squamous cell carcinoma.
So can you do a clipping of just the part that's growing out?
Right. You
Okay.
can get the part of the skin that's attached to the bottom, you can clip that off. It may hurt for a second, but it's not going to be
I
a
can
big
do
deal.
that. That part's fine. I just don't want to do the whole
Right.
part.
Right,
Okay.
but you want to make sure it's not a squamous cell carcinoma.
Okay.
Rarely it could be a verruca, and we know that the HPV virus 16 is premalignant, and it can be something like that. But
Okay, thank you.
yeah, no problem.
Any tips for treating periungual nails? Somebody asked that.
Periungual verruca.
I mean, verruca, yeah.
Right, so periungual verruca are probably a big problem because most people, you know, get manicures, and if they're not recognized early, taking a nail file, trying to clean it, or clipping the nail, you clip one nail, use the same clipper for the other nails, and now you're spreading the virus all over the place. It's very tough. You know, I do a lot of bleomycin injection, very dilute bleomycin, inject into the warts, because years ago, someone getting treated with chemotherapy, their warts went away. So Logix has it, and we created like a diluted, you know, version. We inject it directly into the nail. Liquid nitrogen, patients, you know, they can't tolerate it. The bleomycin hurts, but I mix it with anesthesia, so the little pinch and then right away. Sometimes I use Candida antigen to try to stimulate like an immune response, and we can inject a few of them, and if you're lucky. I never believed in it very much because I never had success until one day I had a young boy that had like 15 warts all over his nails. I'm not going to treat him with bleomycin. I said, let me do a few with Candida antigen. He came back a month later and they were all gone. So I tell patients to wish every night before they go to bed that they want to go away. There's a lot of hypnosis that can be beneficial too. There's a lot of anecdotal things, but they're tough. They're very tough.
Hey there, Valerie Stern. I'm from Los Angeles. Thank you so much for this lecture. It's been amazing. I have a quick question just to clarify regarding the yellow nail and the minoxidil. Are you referring to oral or topical minoxidil when you said that it can actually help the nails as well as the hair?
Right. The studies are coming out now more and more that it's oral minoxidil. Again, topical, like I said in there, doesn't penetrate very well. You have to have a really good transdermal vehicle in order to make it work. So taking oral minoxidil, I think it's a benign medication. If anything, it can make you relax. It lowers your pressure a little bit, but most people, it really doesn't affect them. So oral minoxidil, usually for women, I start them at half a pill, 1.75 milligrams, because they can produce more facial hair.
Exactly.
But it does work. It's amazing for hair and for nails. Yeah.
Awesome. Thank you.
You're welcome.
Somebody asked about Pseudomonas. Any good treatments for that?
Pseudomonas is a tough situation because clearly we don't want to necessarily give oral antibiotics for something that's in the nails. It's basically like the Pseudomonas is using the nail as a greenhouse, right? You have a roof to protect it. You have a space because you have onycholysis. People don't get Pseudomonas unless you have onycholysis, which is the separation, whether it be from psoriasis or whether it be from onychomycosis. So it's a secondary contaminant. It also has the warmth of the circulatory system of the body that keeps it, so it's a perfect environment. Sometimes vinegar soaks, sometimes I use the gentamicin, drops for eye drops and have them drip it in. If they can trim the nails as short as possible, obviously no one wants to get their whole nail trimmed wherever it's onycholytic, but if you remove that portion that's separated, there's no warmth, there's no greenhouse effect, so that Pseudomonas can't live. Don't do Clorox, don't do straight vinegar, do things dilute. It's tough. In the worst scenario, you can give them Cipro orally, but that's like someone who's desperate.
Hi, my name is Tracy. I'm from Newport Beach, California, and I had a question about if there was an age range that you were concerned about or wouldn't prescribe minoxidil or antifungals to?
I don't think that's really an issue too much. I mean, obviously, someone who's 12 years and younger, it's probably not affecting them as much as it is the parents.
Okay.
So usually I say, why don't we wait till your child gets to be of an age where it's bothering him. Mm-hmm. As far as for the use for minoxidil for just trying to get the nails to grow faster, or?
Yeah, like you mentioned, I hadn't heard of that before.
Right. I mean, I wouldn't do that in a younger patient necessarily. I mean, after 18 years old. I mean, most 18-year-olds are losing their hair anyways, men. So it's probably gives you both treatments at the same time. But I don't know if there's a threshold for nail growth and onycholysis and those type of things. From the other point of view, the onychomycosis, I think that there is terbinafine as a liquid, and so depending on how much it affects the child, I would give it to them, but or griseofulvin for that matter, which also comes as a liquid. But as far as taking the pill, if they can swallow the pill, I have no problem with it.
Oh.
Yeah, well, we did some studies long ago that we gave patients 1 week out of every month, and we did 1 week out of every 2 months, and we did 1 week out of every 3 months, and we found that up to 3 months, 1 week is enough to really keep it clear. Once you went more than 3 months, patients weren't responding as well. But it's hard for patients to keep track of every 2 months, every 3 months. So I just say from July 1st to July 7th, you take a week's worth of medicine, August 1st to August 7th. So 1 week out of every month, and I usually say start at the first of the month so you know when you're doing it to keep it easy to remember. But yeah, I think that works good. The allylamine in terbinafine is fungicidal, so it kills the fungus and it lasts a long time. There's no sense in taking it every day for 3 months like the FDA. But when you do an FDA study, you try to make it so it gets approved. But we know that 1 week out of every month. And I also like the 1 week out of every month because like we said, it takes anywhere from a year to 18 months for a nail to grow. And someone's going to take it for 3 months and say, oh, my nail still looks, like it's got disease. They're not going to be happy. So at least they're coming to your office every 3 months to get a prescription, and you can show them that it's growing out. That you take a measurement, you can see that the progression of the nail fungus is disappearing and they are happy. So I think it's easier to keep the patients compliant when you do it like that.
Great. What about cool therapy if they're going through chemo to try to preserve the nails?
They use that a lot for hair. You know, they have those special hats that you put on to preserve the nails. I think that depending on, the patient, it's the tolerance, we have to be careful because too much cold can give you, ischemia, and the distal areas are much more susceptible to problems like frostbite and damage than I would say your scalp, but it's worth a try.
Somebody asked about clubbing. How soon would that appear after pulmonary disease sets in?
Sometimes it can before the disease comes in, sometimes after. I mean, everyone's different, but usually it's got to be more of a chronic situation going on, but the patient may not even notice that they have it. But if the first sign is the clubbing, you should need to refer them out to make sure that we're eliminating that possible cause.
And you mentioned Accutane can cause some issues with nails. Does that usually resolves?
Yeah, I mean, Accutane causes sensitivity to the skin, and patients get pyogenic granulomas. We don't know pyogenic granulomas can occur in pregnancy. They can occur just by themselves. Sometimes when you clip your nail too much or you pull like a hangnail or a cuticle, you can develop like a really painful growth of what we call granulation tissue, which is what pyogenic granulomas are. And patients that are on isotretinoin or Accutane seem to develop those more, whether it be secondary to the fact that they did something to their nails and caused it, or if it just happens spontaneously. But we definitely see more of those in patients that are taking isotretinoin.
Gotcha. Do y'all have any other questions? So I have a question. With everybody getting their nails done and putting their hands under the UV light,
Right.
Do you see an increase in melanoma over the last few years?
I think that we're seeing more skin cancers because I think more people are aware and they're getting they're coming to the office to get visits. Whether you can prove that it's the UV from the nail curing or whether it's just coincidence, that's hard to prove. Maybe 10 years from now we'll have better data, but there's no question that the accumulation of ultraviolet damage, starting from the first day you step out in the sun as babies to us when we get more mature, it adds up. And eventually, in some patients, it'll convert that normal cell into a malignant cell or an atypical cell. So when that happens, we don't know. But tanning beds and any of those things that give you more ultraviolet light exposure, I think are putting you at a higher risk of developing skin cancer, whether it be basal cell, squamous cell, or melanoma.
Gotcha.
So again, as a dermatologist, we try to convince patients not to do that type of manicure.
Try to.
But women are interesting, and men as well. They want to look good, whatever it takes to get their hair, their nails, they'll do it.
Especially down there in Miami.
Well, yeah. We have that Miami glam.
So she's asking, you mentioned using super glue for several nail procedures.
Right.
Do you worry about any kind of contact dermatitis or exposure to the chemicals?
I mean, I think it can happen. I mean, there's Dermabond, which is a medical grade. It's sterile, but it's very, very expensive. So I take super glue with me on any trip because once we were in Hawaii and my son fell on the volcanic rock, split his knee open, I basically put it together and we kept on going without any trouble. But I mean, usually when I'm putting the super glue on, it's when I have the nail plate back in place. So there's very little exposure. And you want to put a little bit and let it dry, and then you can keep putting on layers to protect it. But anything is a possibility.
Okay, I'm Denise from Atlanta. I was wondering, you were talking about the pulse therapy. Don't I understand you to say after 3 months you bring them back, and do you continue, or is it just a
Yeah, I continue the treatment for 1 week out of every month until that nail looks totally clear.
Okay.
Because if a toenail is fully infected, it's going to take 18 months. So the patient's going to go and say, "Oh, Denise, I saw you for 3 months. I took the medicine, and my nail still looks not very good." And she's going to tell her friend and her friend and her friend. So having them come back and showing them every time they come, whether it be 3 months or 4 months, it depends. You don't want to give enough medication for a year and a half because you may never see them. But if you do it every 3 months or every 4 months, you can see the progression. You can say, "Look, you see how it's getting better." The same thing when we treat hair disease. We take pictures of the scalp and we show, "Look, you see how it's improved." Because you can comb your hair one way, put a gel in one way, and the hair can look good. But until you see those follicles or that nail growing out by a picture, it's hard to disprove that. It's hard for patients to say it's not working. It's right there. The picture picture shows the proof.
Do you monitor liver enzymes?
I don't, unless the patient is an alcoholic or has cirrhosis or a history of liver disease. But I think that, it's the same with isotretinoin, with Accutane. I mean, the biggest thing you have to worry about is pregnancy. We used to say take labs every couple of months, but I think the literature shows that that's really not necessary anymore.
Yeah. Anybody have any questions? Last chance.
All righty.
Thank you for joining us.
Thank you.
Hope Cook with DermCast Live.